Okay, and we're back. So for the next session is another industrial symposium. For this session, it is very interesting because we're going to discuss again about COVID. Even though it's been 2.5 years, we are talking about COVID, but as we know in Indonesia, the case is still high. So I think it's quite relevant. And for this topic, we're going to specifically discuss about the use of point of care ultrasound. And I would like to thank GE Healthcare for sponsoring this session. For this session, we will have prominent speakers from Malaysia. We have Dr. Adi Osman. Hello, Doc. Welcome to Indoanesthesia. And for this session, will be led by Dr. Bestadi Sukmono from Indonesia. Please, Dr. Mono.
Okay. Thank you very much, Krisha. Can you hear me loud and clear?
Yes.
I'm back with the microphone. Okay. And good afternoon, everybody. And welcome to this afternoon session, this industrial symposium presented by GE Healthcare. This time is the ultrasound. I've been using a lot of ultrasound in my daily practice, and GE is one of the best producers there is. And we would like to welcome our two speakers. We have Dr. Adi Osman. Hi, Adi. How are you? I haven't seen you yet. Okay. Hello. Okay. Yes, he is the one of the top emergency physician from Ipoh. Hi. And
Hi.
He and I are actively teaching people using ultrasound, both for general practitioner and anesthesiologists. We're both in the WIN-focused group. And if you might remember, 2 or 3 years, no, I think it's about 4 years back, we still have the WIN-focused session for everybody in Indonesia, and Dr. Adi is one of the first one who came here to Indonesia. And today he's going to talk about focus point of care ultrasound for COVID. And I believe the time is yours. I don't need to further introduce you, and you may start your slide. Thank you.
Assalamualaikum and very good evening, everyone. So first and foremost, I would like to thank organizing committee led by Professor Susilo and also to GE for having me in this conference. My name is Adi Osman from Malaysia. I will talk about this topic, focus for COVID, the role of ultrasound in managing COVID-19. So when we first facing this COVID-19 pandemic, and this probably the first time that we have to do ultrasound in the full PPE. So this picture illustrates how the ultrasound in COVID-19 in full PPE. So everything look like blur. It's like driving a car in heavy rain, whereby everything that is object in front of you looking like invisible, right? So over the time, we actually able to overcome this problem. And today, we discuss about this article that published by us in a few months ago, entitled the multi-organ point of care ultrasound for COVID-19. This article is actually an international expert consensus whereby we discuss in further detail a consensus how to use ultrasound basically in COVID-19 patients. The first thing that we can do with ultrasound in COVID basically is a potentially useful focus application in COVID-19 patient is in patient with a respiratory failure, whereby we can come up with a possible diagnosis, and of course we can do a triage at admission using lung ultrasound point of care echocardiography, basic echocardiography, and also in DVT scan in patient with suspect DVT or pulmonary embolism. Second, we can use this lung ultrasound, mainly lung ultrasound and echo, to look at the possible phenotype, and of course, in monitoring of this COVID patient. Number three, this is one of the most important components in managing COVID, whereby we need to doing the assessment, the cardiovascular assessment, whereby we need to screen for pre-existing disease, probably a sepsis-related myocardial dysfunction, myocarditis, for example, patient with the LV or RV dysfunction, and also those with acute copamina, basically by using the focus or basic cardiac focus ultrasound. Number four, this is another important usage of focus in COVID, whereby we can assess the fluid status. We can use it to screen for patient with severe hypovolemia, we can determine whether the patient is fluid responsive or fluid tolerance. Okay, we can assess the fluid tolerance, and of course, in patient with a possible fluid overload, we can use this focus to diagnose and screen for DVT, deep vein thrombosis, and of course, it is very important in mechanically ventilated patient, whereby we can use this focus as a guidance to look at the recruitability assessment, the PEEP titration, and of course things like pronation response, and of course the prediction. And we see the assessment, the effectiveness of all this changing in posture from, let's say, supine to prone position. Then we can, most of the time, we use lung ultrasound. Next, we can look at the possible complication due to the mechanical ventilation. For example, atelectasis, in cases whereby the possibility to have, in a patient with positive pressure ventilation, possibility to get this pneumothorax. And of course, we can use it in the weaning of mechanical ventilation. And of course, things that we can diagnose and we can assess things like pulmonary edema. And in these type of cases, we might need to use additional, for example, muscular ultrasound, etc., on top of lung ultrasound and basic cardiac, focused cardiac ultrasound. And we also can look at the secondary organ dysfunction with the diagnosis. For example, a patient with a possible abdominal complication, a patient with AKI, whereby we need to use additional, for example, hepatic vein Doppler, and of course, abdominal ultrasound. In patient with potentially having this problem, or we suspect the patient having this problem, for example, a stroke diagnosis and neuro monitoring, whereby we can use focus to do a transcranial Doppler or measurement of this optic nerve sheath diameter. And last, the advantage of focus as compared to other imaging modalities, it is simple, and there's a lot of technological advancement that enable us to use it as a teleconsultation or telemedicine, so we can actually get a second opinion. And of course, okay, this is actually make it possible because of the technology, make it possible for us to use it as a remote training. So this is actually the 11 usage, possible potential usage of point of care ultrasound in COVID-19. We go one by one. The first possible usage is in terms of, especially in emergency department, whereby you can use it to triage patient. And we know, based on evidence, the lung ultrasound is more accurate than chest X-ray in diagnosing respiratory condition. For example, it's not just limited to the respiratory condition per se. You also, for example, in patient with interstitial disease, in pneumonia, and of course, there's a lot of evidence now, the usage of lung ultrasound in COVID-19 pneumonia as compared to chest X-ray. And of course, lung ultrasound shows a good agreement with CT scan in recognizing the lung pathology and of course, in determining the severity. So I'd like to share this conceptual framework of a point of care ultrasound used for triage in dyspneic hypoxic patient during the SARS pandemic, SARS-CoV-2, okay, in COVID pandemic. And of course, when we look into this diagram, it does not represent an algorithm, but rather a framework for potentially developing the protocol. Of course, based on local institution, clinical practice, policy, and regulation. So it does not either provide a list of conclusive diagnosis. If you go through this algorithm diagram or specific treatment, but it's rather provides some example of diagnosis which suggesting how to integrate this best focus in the workflow of this specific setting, which is the emergency department. And of course, if you look into detail, there's three components of this algorithm, which is important. Number one is the etiology assessment, the diagnosis, the possible diagnosis. Number two is the severity assessment. Of course, this should be based on degree of we call it a respiratory compromise, which include the potential for rapid deterioration. Okay, should be assessed, and of course, it should include the breathing pattern, the SpO2, the ABG, lactate, for example, and of course, we include the lung severity, and of course, the focus and DVT finding, and last will be the patient cohorting, whereby we can determine where is the best to place this patient in based on all these criteria. And of course, we include the focus component into our clinical and some biochemical result. The next thing that we can use this focus, basically the lung ultrasound, is looking in terms of diagnosis patient that presented to us with respiratory failure. In this chest X-ray, this is a patient that presented to us with respiratory failure with contact of COVID-19 patient. And you can see there's a haziness involved the left lower zone. And this is actually the ultrasound, lung ultrasound, specifically looking at this area. So with this, in this image, video, we can see clearly there is a sign of consolidation there. And the other thing that we normally see in COVID-19 is that what we call a subpleural, this you see the subpleural echo-poor region, this subpleural tissue-like echo texture, which resemble a lung consolidation, which is quite common in patients with COVID-19. This is what we call a bronchogram, or sometimes we call it a bronchoaerogram, which is the same. And it is a tree-like ramification, which seen most of the cases, almost 87% of the cases. And this extensive reflex of this bronchotree that run between the consolidated portion of the parenchyma. Right. The another important things that we need to differentiate between these two. This is based on opinion by Matthias Jihab, in which he published this textbook of this chest ultrasound whereby according to Matthias, there is a way to differentiate between pneumonia and pulmonary infarction. One of the way to differentiate between these two etiology by looking at the circulation, the vascular properties of this consolidation. In pneumonia, because of inflammation, you see there is what we call it vascularity, increased vascularity into the consolidation, right? This is a inflammatory process. But in infarction, because it's a block in this vascular, especially in the arterial part of it, so there is a acute termination of circulation of vascular just before it enter into this consolidation, right? So why this is important in COVID-19? This is actually a guy that presented to us a few days after being diagnosed as a COVID positive, CAT1 or CAT2, and presented to us with a severe difficulty in breathing. And we do a focus that shows possible acute right RV dilatation. And we suspect there's acute cor pulmonale, and we proceed with the CT thorax, okay, CTPA, and what we see, this is actually a subpleural kind of consolidation. And when we put, we don't find so much of this acute termination of vascularity into the what call it, the consolidate this lung consolidation. But when we found, okay, when we put a color Doppler, there's nothing there. So in these type cases, this is actually typical of the consolidation in pulmonary infarction. Okay, and we see a number of patients with a pulmonary embolism that presented with this kind of lung pathology and this lung finding. So looking back into how we use lung ultrasound in monitoring COVID patient, especially when we want to look at the we want to evaluate the lung aeration. The first thing that we need to do is to have a standard report of a comprehensive examination. This is very important because it's not enough for us to put there your lung ultrasound finding is a consolidation scene. It can be anywhere. And it be very difficult in terms of documentation when the second person that saw your finding to determine whether patient is getting worse or getting better. So that's why a comprehensive standard kind of reporting, they must be there if you want to use a lung ultrasound, especially in COVID patient. And there should be a serial comparison, not when doing one lung ultrasound and start a treatment, and there's no follow-up in terms of looking at the changes or improvement in lung ultrasound. That's why very important, it should be a serial comparison. And of course, the why we use it is when to use it is actually to monitor patient in the term of monitoring patient with COVID-19. And the other thing is this kind of basic, but this is a fundamental lung ultrasound examination in any patient. Number one, supine, okay, they identify the bad sign, yeah. But the most important thing I notice based on my experience, especially in those beginners in lung ultrasound, is it's very important to us to determine where is the diaphragm. Yeah, where is the diaphragm? Because when we get the diaphragm, it's easy for us to differentiate whether this is a liver or spleen once we actually identify the diaphragm. Because sometimes what we see is a liver, and if you're not careful enough, you're going to diagnose a lung consolidation based on the actual liver, because that's why you call a liver-like pattern. Okay, liver-like pattern. So I personally think it's very important for us to determine where is the diaphragm. Then we can determine whether this is actually the actual lung consolidation, especially when we talk about right L4 or L5 or posterior lung consolidation. And the other important thing is to determine the anatomical landmark. So these are a few ways to do it. One, we identify where is your anterior axillary line, posterior axillary line, okay, lateral, anterior, and divide it into these few hemithorax. Okay, this is anterior, this is lateral, and this is posterior. We have a superior and then we have inferior. Why this is important? Because in terms of communication later on, right? And I'm going to talk about how to use it, but the basic fundamental, the four things that you need to do must be fulfilled first, right? Right. We have this list and documentation of lung ultrasound, whereby we base on this article, which published by in Blue Journal in 2011 by Bohimat. And each of these region, we actually score it between 0 to 3. And how to do it? Number one, if you see a presence of horizontal artifact of A line beyond the pleural line, this characteristic of the normal pleural aeration. So we give 0. Okay? Going back into this, normal will be 0, right? Next will be when we see a presence of multiple, a well-separated vertical B line, which correspond to moderate decrease in a lung aeration resulting from interstitial syndrome. So you can see a B line there, you can see a B line, and you count it's more than 3, so it's significant. And there is a multiple, okay, and well-separated kind of vertical B line. So we put 1, right? Next, when we start seeing this B line coalescent, okay, which correspond to more severe decrease in lung aeration, which resulting in partial filling of alveolar space, probably by pulmonary edema, or probably due to confluence of this bronchopneumonia. Okay, so 0, 1, 2, okay, and last, when we start seeing the lung consolidation, which respond to complete loss of lung aeration, which persistent aeration of the distal bronchiole. This sometimes we see a bronchogram at the end, and sometimes we see a flip bronchogram. So we come out with this chart, and we actually score, for example, we divide it into, as I mentioned earlier, the anterior, the lateral, the posterior. We subdivide it into few hemithorax, thorax, the superior, the inferior, the right, and the left, and we score it. The other way to do it is to score the re-aeration. The one I mentioned earlier is to score the lung. Now we can actually look at the lung, whether your maneuver, for example, when you do a PEEP titration, when you do a recruitment maneuver, and you can actually score each of these changes by looking at how good is the change improvement. For example, a good example, if you see a patient with a consolidation like this, and you increase the PEEP length from, let's say, from 0 to 16, and you see from consolidation straight away it goes to the A line, and you give a 5 point, right? The other thing that we can use this lung ultrasound is looking at the possible phenotype to identify the possible phenotype. So just a good example, this is actually a male, a 64 years old male hypertensive, okay, and presented with a PF ratio of 105 or 105, and the final PEEP is set at 10 centimeter water. You can see here, okay, the lung ultrasound score is 11, okay, and you can see there is a lot of separated kind of vertical B line, this which is probably consistent with the phenotype L, the one with the needed a low PEEP with a high compliance, okay. And this is not the case, 74 years old hypertensive male with a chronic with CAD, okay, and chronic kidney failure, presented with very low PEP ratio of 82, with a final PEP of 14. You can see here, there's a lot of kind of coalescent kind of vertical B line. And this is a good example. This is probably a patient with a phenotype H. They require a higher PEP with a low compliance, a patient with a low compliance, right? The other thing that we can use, especially in mechanically ventilated patient, that we were planning to do a weaning process, is to use a lung ultrasound to quantify the extension and, of course, the resolution of pulmonary edema. This is another example. Patient that presented to us post-extubation, deteriorate, desat after post-intubation. Then when we do a lung ultrasound, we found there is the coalescent kind of a vertical V line. And of course, after nitrate and putting patient back on CPAP, okay, you can see improvement. Now the coalescent type of a V line now become well separated vertical V line. So based on recommendation by this International License Committee on Lung Ultrasound, they suggest, which is a strong level A, in patient with cardiogenic pulmonary edema, the B line should be evaluated because it allows in terms of monitoring and respond to therapy. And of course, patient with increased intravascular lung water, assessment of lung aeration can be assessed by demonstrating a change or decrease in number of B line. For example, from coalescent B line to the well separated, reduction in number of B line. So I think everybody know about this article we published by Boppocelli in somewhere in last year, whereby they describe very interesting finding, in which they call it a light beam, and they describe this artifact which respond to early appearance of a ground glass alteration, and we typically in acute disease. And they describe it as a broad, you can see as a broad, loosen, the band shape, the vertical artifact. And if you look carefully, it arises from the pleural space. It's something like the B line, but it moves with sliding. And at times, it creating a kind of on-off kind of appearance. That's why they call it a light beam. Just to differentiate this typical B line. This is a typical coalescent vertical V line. You can see from here. You see the B line, which is coalescent, and it moves with inspiration and expiration. This article looking at the associate cardiac injury in mortality in patient with the COVID-19 is based on Wuhan experience. What they found is actually those with cardiac injury, the survival rate is lower compared to those without cardiac injury. And there's another interesting article published by Ciccone et al., this group, whereby what they found is normal echocardiographic findings were reported in almost half of patients with COVID-19. So in fact, in this type of patient, the LV function is almost normal, right, 50%. And they also found in COVID-19, the RV dysfunction seems more likely associated with increase in terms of mortality. So that's why giving us back to this important question. When we want to look at when we want to use the focus in patient with COVID-19, okay, when we want to look at the cardiovascular assessment, we need to go back into this fundamental hemodynamic consideration. Okay, just imagine this is a glass, which is when we talk about hemodynamic, we have this what we call it the stress volume, right? And of course, we have this non-stress volume, and the one that contribute to the pressure that push the blood from point A to point B is the stress volume, right, which is generated. Okay, and going back into this illustration, okay, this stress volume that create a pressure, and it's very important. This is what we call the mean systemic filling pressure, which push the blood from aorta, from the after the left ventricle, okay, to the to the superior vena cava and inferior vena cava, the whole circulation. Okay, and the most important thing is actually this, the venous return gradient. I will use a lot of this terminology. Okay, mean systemic filling pressure and venous return gradient. And we look back into the Starling curve, our famous Starling curve. Okay, and when we talk about hemodynamic consideration, when we want to personalize or individualize the fluid management in COVID-19, we need to understand this curve, what we call it venous return curve. And when we give fluid, we actually increase the mean systemic filling pressure. And of course, it must fall within this stiff area of this Frank-Starling curve. But the problem is we forget the most important crucial hemodynamic consideration. In this Frank-Starling that I mentioned earlier, this is normal cardiac function curve. In some patients, especially the one that severe COVID that we see, they are elderly, they have multiple comorbid, and most of the time, they have limited in terms of pulmonary and cardiac reserve. And most of the time, they presented with impaired cardiac function. Right? So, giving fluid in this type of patient will not change in terms of cardiac output or even venous return. Of course, some people use CVP, which I think it should be abundant, okay, and use it to determine the fluid responsive and fluid adequacy in this type of patient. So this kind of things that I got surprised is still being practiced. So if you ask me, if I want to use a focus in COVID-19, this is a 6 thing that I probably can consider. Okay, for example, if I want to look the overall cardiac morphology, I want to look at the cardiac functionality, I want to estimate the cardiac output. The most important, I want to look at the preload assessment and responsiveness, and of course, I use it, for example, in a cardiac guided ultrasound guided procedure, right? So the other thing that we use in COVID-19, this is a good example of 2 patients that we saw. This is actually a 32 years old that non-comorbid. We suspect a myocarditis based on a lot of ECG changes, okay, significant ECG changes, and elevated in cardiac enzyme and impact cardiac function. You can see the dilated LV, reduction and LV systolic function. And basic rule for me is quite easy to look at diastolic dysfunction. If you see LA dilated, LV dilated, the diastology, okay, the diastolic function, okay, impossible to be abnormal. So you can simply say this is abnormal diastolic dysfunction, okay. And you see hyperacuic increase in echogenicity, right? And the other case almost similar. Okay, this is a young patient that presented to us with myocarditis. You see a dilated LV, okay, and you see a reduction in myocardial contractility in terms of LV, systolic and diastolic function, okay, and you can see the hyperacuic, okay, hyperechogenicity, and of course because of the elevated in cardiac enzyme and the ECG changes that suggest a myocarditis or pericarditis, we diagnosed this both patient with the myocarditis. The other interesting part of fluid assessment is if you want to look at the heart-lung interaction. Okay, we know when we breathe in, the diaphragm is descend, and because of the change in this intrathoracic pressure, okay, and we reflected into the RA. So what happened is actually there will be increase in venous return gradient. Okay, so it kind of suck the whole blood from SVC and IVC into the RA. So what you see is a collapsibility of the IVC. Right. When you have patient with hypovolemia, the mean systolic perfusion pressure will become low. So the back pressure will become low. So this collapsibility of IVC will become more pronounced. But it only works in spontaneous breathing patient. Okay. What happened in patient with positive pressure ventilation, in ventilated patient? So rather than saying the collapsibility, okay, and every time the ventilator give a tidal volume of positive pressure ventilation, what happened is actually the IVC will distend. Yeah. In patient with a low mean systemic filling pressure, a hypovolemic patient, what happened? This distendability become more pronounced. So what I'm trying to say is, in spontaneous breathing patient, we see a collapsibility of IVC. Okay. In intubated patient, we see distendability of IVC. Of course, in patient with spontaneous breathing in between mandatory breath, or patient in, for example, in NIV, we don't know which and which. So this become unreliable, right? The other thing that I think is much better than IVC is using the VTI. Okay, this is the parasinal long axis. This is LVOT. If you can actually measure the amount of blood that goes into the LVOT every time the left ventricle contracts. Okay? This is actually the stroke volume. Okay, and of course, stroke volume. This is the mathematical calculation how to see the stroke volume. Okay, and this is actually the cross sectional of this aortic aorta. Okay, and VTI is the good representative of a stroke volume, because the CSA, the cross sectional of the aorta, is constant. So the change in VTI reflect the change in stroke volume. Similar, when we look at the heart-lung interaction, okay, if there is a change, okay, in VTI during inspiration and expiration, we can use this to determine whether patient is fluid responsive or non-fluid responsive. Okay, this is VTI. This example, this is a parasinal apical 4-chamber. Yeah, you can see the 5 chambers, right? Apical 5-chamber, and you can put your PW there, and you can see this is a VTI. In some good ultrasound, it's a kind of automated software whereby just one click, you should be able to get the VTI, for example, in this video. And you can see there's not much variation in terms of VTI. This is, you see the VTI envelope there, and there's not much, this a peak, there's a peak of VTI, there's not much variation. So this patient might not be fluid responsive. A good example, this is fluid responsive. You see a variability in VTI, and this is another patient which is non-fluid responsive. You don't see much of the variability in VTI. Okay? You can do this superior vena cava. It's quite difficult in transthoracic echo, but if you have an opportunity to use transesophageal echo, you can see this is bicaval view. You can see the superior vena cava there, series vena cava there. This, you see a collapsibility of superior vena cava, and you don't see much of the collapsibility in superior vena cava during inspiration, expiration. You can use this, or you can use the one that I mentioned earlier. This is IVC. This is IVC. You can see the variability. There's not much of variability in IVC in patient which is fall into the category of non-fluid responsive. The other thing that I want to illustrate, want to emphasize here is the usage of this interesting technique. We call it a passive leg rising test. For example, in this is our case. We use a transesophageal echocardiography to look at. Yeah? And this is the BTI. You see whether by elevate the lower limb, there will be increase in BTI. Yeah? And this signify this patient probably are fluid responsive. The other thing that we can use focus is to look at the ecodynamic parameters after vasopressor or any inotropes. We know that one of the things that we use is to look at this atelectasis. And there's two types of atelectasis. One is obstructive and one is obstructive atelectasis, right? And the things that we can use this lung ultrasound based on our experience is to look at the partial reventilation. We do it a lot. We see it a lot in patient after pleurotype, for example, fluid aspiration. And of course, we see a lot in during inspiration, aspiration, right? Just to give an example, this is what we call a partial reventilation during expiration. You can see a consolidation. Every time the ventilator delivers tidal volume, you see from consolidation it become the B line and some of it become coalescent kind of line. This is what we call a partial reventilation during expiration, right? So we can use this lung ultrasound to look at the effectiveness of, for example, in patient that you do a lung recruitment. Okay, this is study that whereby we use transesophageal ultrasound, looking at the posterior or basal atelectasis. Looking back into this CT scan, this is esophageal, this is descending aorta. So when we put the ultrasound esophageal TE here, so we should be able to see this area, and this area, okay, which is represented by this video. This is the atelectatic lung. This is pleural effusion. Okay, is somewhere here. We can use this evidence. We can use this lung ultrasound, for example, by using this transesophageal, in determine the effectiveness of our PEEP titration and looking at the lung aeration. Okay, when we do a recruitment maneuver. Okay, you can see from this two video. This is when we increase the PEEP. This is from 8, from 5 just now. Okay, you can see just this is consolidation. Then you start seeing the disappearance of this consolidation and will be replaced by B line. Okay, and coalescent B line at the end become well kind of separated the B line. When we increase the PEEP, okay, SpO2 also we seen they see increase from 85. When we increase the PEEP to 50, we see less consolidation now, which is replaced by the B line. And improvement in SpO2. Yeah? And when we increase the PEEP to 20, we can see the SpO2 improve to 90. And we don't see much of this vertical coalescent kind of B line consolidation. Now we replace by this B line. Okay, similar to this. This is a PEEP titration technique. This is using Mato technique, whereby you just increase the pressure to 35 centimeter water, okay, at the 30 second, 30 to 35 second, right? And you can see by increasing this, okay, we actually improve the SpO2. This is just a look from P5 just now to P25. You can see improvement in lung, the disappearance of lung consolidation, which is placed by the B line, and of course improvement in SpO2. Right. The other thing that we can use this lung ultrasound is to determine the possible complication, especially in ventilated patient. For example, in pneumothorax. I think by now everybody know how to determine pneumothorax based on lung ultrasound. One of the pathognomonic of this pneumothorax in lung ultrasound is what we call the lung point. Okay, whereby if you see absence of the sliding sign, you put M mode, you're going to see this, right? Alternating patterns of presence and absence of B line, and this is what we call the lung point, right? Okay, you can see there is absence of sliding sign, presence, and absence. This kind of alternating patterns of absent and presence of sliding sign. And you put M mode here, you're going to see this kind of pattern, and this is called a lung point, right? So in summary, this is actually the potentially useful focus application in COVID-19, ranging from triage, emergency department, whereby patient with a possible respiratory failure in terms of diagnosis, in terms of cohorting, looking at the severity, judging where to put this type of patient, and determine the possible phenotype, right? And of course, in monitoring, as I mentioned earlier, and using it to determine the cardiovascular, okay, to assess the cardiovascular, to look at the fluid status and fluid assessment, okay, and of course, in helping us in terms of guiding us in patient with mechanically ventilated. This is actually the 11th thing that the possible potential usage of focus in COVID-19. With that, thank you very much.
Thank you very much, Dr. Adi Osman, for the very detailed presentation. I don't think we have much time here. We're going to move on to the next presentation. I see that there are a few questions waiting for you in the Q&A boxes. I think you can start to type them, Dr. Adi. And we hope we still have time for a live Q&A after this.
Yeah.
And we're moving on to the next speaker, I think. Sir Kamarul?
Yes, I'm ready. Yes.
Okay.
All right.
Let's start your video.
All right. Hello everyone, I am Kamarul from GE Healthcare ASEAN. I'm here to present the Venue Family Ultrasound, our ultrasound made specifically for point-of-care ultrasound users, and I will also like to touch on our latest handheld ultrasound called Vscan Air. I would also like to take this opportunity to thank the organizing committee members for giving us the opportunity to present on our point-of-care ultrasound products. A little bit of myself, my name is Kamarul, I am the Clinical Marketing Manager for ASEAN. If you want to reach out to me, you can contact me on the contact details I listed on screen. If you have any future collaboration you want to do in Indonesia or ASEAN countries. We have supported a lot of events across ASEAN, and I would like to thank those who have collaborated with us previously on this matter. Thank you from the bottom of our heart. But now, since the pandemic, things have changed and we have to adapt. So as you can see on screen, more and more events are done online, like we are doing today. We have done a few events in regards to POCUS with the speakers across Indonesia and also ASEAN. So what's going to happen today? Today, I will be presenting on the product called Venue Family Ultrasound and Vscan Air, our latest wireless handheld ultrasound. Later on, I'll pass it over to Geraldine, our clinical application and education leader for Southeast Asian countries, to do a hands-on demo on Vscan Air. As you know, POCUS users have increased among ultrasound users, expanding beyond emergency and critical care. Even anesthetists are using POCUS to assess pre, peri, and post-operative assessment using ultrasound. Normally in critical care patients, shock is a common problem you have to deal with every day. Using conventional or traditional ultrasound to treat patient in shock can cause the delay in the treatment of patient in shock. And as you know, if you do not reverse the shock within 3 to 5 minutes, the outcome will not be good for the patient. So that is why GE Healthcare point-of-care ultrasound team decided to create a specific point-of-care ultrasound with artificial intelligence or AI and machine learning built into the ultrasound system to manage patient in shock. We call this group of ultrasound Venue Family Ultrasound. Venue Family Ultrasound consists of 3 models: Venue, Venue Go, and Venue Fit. The Venue, which has a 19-inch monitor and 4 hours of battery life, was launched in 2017. And then Venue Go, which has a 15-inch monitor and 2 hours of battery life, was launched in 2019. And finally, Venue Fit, our smallest model yet, was launched recently this year in 2021. For Venue and Venue Go, the special thing about this model is that we put artificial intelligence or AI and also machine learning into the machine. What are the AI tools that we have? The AI tools that we have when we first launched Venue in 2017 was Auto VTI, Auto IVC, and Auto B-Lines, which is to target shock management in patients. And then in 2021, we added real-time EF and also lung sweep. In between 2017 and 2021, we thought of how to add further value to this AI tool. So we targeted on documentation. We have created few documentation tools to help you in your daily practice. We have VTI trending, EFAS diagram, and lung tool to help document your findings. Auto VTI is the first AI tool we created. Get your apical 5-chamber view. With a single click of a button, the AI will automatically calculate the VTI and give you your cardiac output once you have calculated the diameter of the LVOT diameter. It also saves up to 82% in time saving. If you use a conventional ultrasound, to get the VTI, you have to click the ultrasound 14 times. So with Venue, it's only a single click. As you can see in the box in the middle, it changes color from red, yellow, green. This is our quality indicator. If your scan of the apical 5-chamber view is bad, the color will become red. When it's in the middle, it becomes yellow. And when you get the best view, it will change to green. This is our AI guiding you to get the best scan quality. With machine learning, the detection of our AI tools will get better the more you scan. For fluid resuscitation, we also have Auto IVC. When you get the IVC, single click of a button, it will automatically detect the minimum and maximum diameter and gives you the collapsibility index or distensibility index depending on the state of the patient, either ventilated or not. It saves up to 9 times clicking on the ultrasound button of a normal conventional ultrasound. As you can see here, the green stick changes color according to your scan. This is another of our quality indicator to guide you in scanning of the IVC. Another tool that we have that is very relevant in today's pandemic is Auto B-Line. When you scan the lungs and you see the B-lines, single click of a button, it automatically calculates the B-lines and show you the frame with the most number of B-lines. The line you see here is our quality indicator to show you how good the scanning of the lung is. Another tool we created that is relevant during this current pandemic is the lung sweep. You can click on the button on screen or just use gestures. It will automatically swipe the whole lung on anterior, middle or posterior part of the lungs. A great tool to have if you want to have the whole view of the lungs. The next auto tools that we have is real-time EF. You get the apical 4-chamber view. With a single click of a button, it automatically traces the borders of the left ventricle and automatically gives you the ejection fraction. All this with the help of our AI. As you can see, we built a quality indicator. The quality indicator acts as a guidance system using our AI software. If your scan is bad, it becomes red. If you improve a little bit and your scan is in between, it becomes yellow. And if you achieve the best view, it becomes green. Each AI tools are built with a specific quality indicator in order to assist or guide you in your scanning. This tool is great for those who is just learning to scan and trying to perfect the art of focus. Other than the AI tools, we know documentation is really important. That is why we created some documentation made easy in the system. For Auto VTI, we have VTI trending. All the results you get from using Auto VTI can be stored and used to monitor the patient's progress. As you can see, the line changes from red to green. The green indicates the VTI results is improving and your treatment is working. Other than that, we also have EFAS diagram. Instead of eyeballing and try to memorize the frames of each patient of the EFAS protocol scan, you can use our EFAS diagram. Scan the needed parts and just press store. It will automatically move on to the next scanning segment, and once you're finished, you will have an overview of all the scans. Really good for documenting purposes and to monitor trauma patients. We also have lung diagram. It is similar to EFAS diagram. You can scan each part of the lungs and store your images of the whole lung on a diagram. It will give you a rough idea of what's going on in the lungs of the patient. You can store as many frames as you want and use it to monitor the progress of the patient. So, in a testament to our Venue and Venue Go, we have a few hospitals that have already purchased the Venue system here in Indonesia and also across ASEAN, especially the Venue Go. As you can see in the picture slides, we have many doctors across Indonesia that have purchased the Venue and Venue Go ultrasound system, and all of them are very happy with the purchase. Since I cover ASEAN, I can share here that Dr. Sutapon from Bangkok, who is the Wind Focus Director of Thailand, have been using Venue ultrasound. She was also even featured on national Thai TV news on using AI in our Venue ultrasound. Even doctors in UK bought a total of 700 units of Venue Family Ultrasound under a special COVID budget last year. As more and more doctors are putting their trust in our system, we will improve and bring you more AI tools in the future. We also have white papers published for our AI system. We had Dr. Adrian Wong and Dr. Johnny Wilkinson talking about AI in the papers that they published. Doctors from South Korea who use our AutoB lines in the management of patients in COVID-19 pneumonia, and many more articles that have been produced. Venue Family Ultrasound has won many awards for the design and integration of the AI tool in an ultrasound, as you can see right here. So now, let's move over to our handheld ultrasound called vScan Air. GE has been in the handheld ultrasound industry for quite some time. We have created a lot of models throughout the year. In 2010, we created vScan, the first ever pocket-sized ultrasound that have revolutionized the way doctors see patients. Then 4 years later, we created the dual probe, where you can see two probes in one design on our handheld ultrasound. Then 3 years later, in 2017, we created a fully touchscreen handheld ultrasound device to help in your clinical needs. In 2018, we created GE Marketplace, where you can download apps to help in your daily needs. And in 2021, we released vScan Air, which we want to move forward for the future of handheld ultrasound. We have been in the market of the handheld ultrasound for 10 years, and we have sold more than 20,000 units of handheld ultrasound globally. Because of the Signal Max technology processor, the technology brings console quality ultrasound images into our handheld ultrasound. This is all the clinical images that we got off from our vScan Air. As you can see, the image quality is excellent.
My name is Geraldine, the Clinical Education and Application Leader for GE's Point of Care Ultrasound. vScan Air is the newest offering from the vScan family, a pocket-sized ultrasound that allows users to be able to look into the whole body with a dual probe connecting wirelessly to an app on your smartphone or tablet. Here is the hard plastic protective carrying case for the vScan Air probe. And also a wireless charging pad. The vScan Air is engineered with Signal Max technology for crystal clear images and the power of a high-performance ultrasound machine in a small, lightweight, and wireless dual probe that comfortably fits in the palm of your hand. Our proprietary Signal Max technology, it is now possible to provide crystal clear images in a highly ergonomic and portable device without compromise. Let us now move to the vScan Air app. The app is available for download from the Google and Apple stores. There is flexibility of using an Android or an iOS device, which could be either a smartphone or a tablet based on the user need or preference. The quick boot up and connection to an already paired device happens in less than 30 seconds. As you can see, the display of the clinical information is prioritized on the screen to have a larger clinical image as possible. The app supports scanning in both portrait and landscape orientation. The user interface is based on the award-winning Edison design system that has been validated to be intuitive and consistent for healthcare software. It has been optimized for operating the controls with the thumb while holding the display device and scanning with the other hand. All the primary functions are easily accessible with no hidden menus. vScan Air supports flexible data options. You could share images, videos to generic image sharing apps, or could export data to configure DICOM servers or a shared network. Gain and depth gestures are available to adjust the image during the live scanning. Overall gain can be adjusted by sliding a finger horizontally anywhere on the image area. Depth can be changed by sliding the image upwards or downwards to move the region of interest into focus. It is also possible to pinch and zoom the image in and out and pan a specific area of the image. A few presets have a penetration button in the black and white image mode for better visualization at a larger depth or imaging challenging patient. The lower part of the image houses the color flow, freeze, and store button. You can press the freeze button or tap anywhere on the screen to toggle between freeze and live scanning modes. A cable-free probe design means that the probe could get dropped more easily than one that is attached to a device with a cable. This has been considered in the design, and vScan Air meets Military Drop Test Standard MIL-810G. The probe is also designed to be completely waterproof and has an IP67 rating. This makes it fully immersible in cleaning agents and amenable to high-level disinfection techniques. The regulatory labels on the probe are laser engraved, making it very convenient for cleaning and disinfecting.
If you have any questions or inquiries on all the products you see today, feel free to contact me or reach out to GE representative in Indonesia, Miss Yuli, which I leave all her contact details here on the screen. Leave your contact details and we will follow up. That's all for today. Thank you.
Okay, thank you very much, Mr. Kamarul, for the very, I know it's kind of the gadget of our dreams, you know. And I don't think we have much time left. We are very sorry we don't have a live Q&A sessions. We are very are very thankful for Dr. Adi for the very detailed presentations. And I see that you have already answered most of the questions. I hope to see you again in Indonesia real time soon. And last but not least, thanks to GE for the presentation for the device. We'll be very happy to be using your device in the near future. And I've been using the Venue family and it's very good. Okay.
Thank you, Dr. Mono.
And hopefully this pandemic will be over soon. But one of the great impact of this pandemic is to teach us ultrasound for even the GP are now using ultrasounds handier than most of us. But we don't want to go there again. But that is the nice impact for the pandemic. And I would like to thank everybody who's watching this presentation, this session. Thank you for participating. And thank you all and be healthy. Assalamualaikum warahmatullahi wabarakatuh. I'll give the screen back to Krisha. Thank you very much.
And thank you, Dr. Mono, for moderating the session. Thank you, Dr. Adi. Thank you, Mr. Kamaru, for giving the very nice presentation. So, well, I think the band is ready to play before we move on to our final session of the day.